Dr. Satwik, thanks very much for your time this evening. We last spoke to you about 3 weeks ago when India was reaching what you called a calamitous situation. More recently, we've heard that COVID infections have been easing there somewhat. Is that what you're seeing?
That's right. I'm happy to communicate glad tidings. We seem to be past the peak. We peaked somewhere around the first week of May, but now there seems to be many signs of recovery. Our test positivity rate is coming down from a little above 23% at the peak. It's now down to about 15-16%. Our active case doubling time has come down, has gone up from about 11 to about 36 now. And the number of cases, the cumulative number of cases reported every day is now about roughly 260,000 a day. But you must realize that this is a country the size of a continent, and you can always get an agglomeration of peaks and ebbs, and therefore it's very difficult to describe the situation as a singular, monolithic epidemic in the country. It's always going to be an agglomeration of various peaks and ebbs.
Of course. What about the demands placed on India's health infrastructure at the moment? Has that eased at all?
Yes, it has. What's happened is that the epidemic is now moving centrifugally. It's moving from the metropolitan areas and the large urban centers and the tier 1 and tier B cities, and it's moving into the rural hinterland. And these are areas with unspeakably scarce healthcare infrastructure and resources to test and treat COVID patients. And we're reading ground reports which tell us about these, it's almost like this mortifyingly sinister illness is coming and causing the ruination of entire hamlets and villages and districts. And what seems to be happening, particularly in the Gangetic plains of North India, where it's particularly bad, is that there seems to be this almost attempt by some of the states affected, the officials of some of the states, to redact and obscure data as regards the total number of infections and the total number of deaths before they are put out as official data. So we'll never know the true numbers, but we have some ground reports that mention, vast numbers of dead bodies being buried in the sandy ravines alongside riverbeds, and numerous cremations. And sometimes you just have the wood used as during these funerals and these cremations as a sort of proxy and surrogate for the total number of deaths. The official number of deaths in India per day, roughly a little over 4,000. But public health experts and biostatisticians and mathematical modelers are saying that the true numbers could be 5 to 6 times that or even more.
These COVID numbers in India have been staggering any way that you look at it, as you say. How does the Indian variant compare to others in terms of how transmissible it is?
So we are privy to some information. There's a lot of work that's currently underway as regards the details, the molecular details of transmission of this particular variant. And what we're finding is that this time round, when the variant was hitting the large urban centers of Delhi, the cycle threshold value at the time of the RT-PCR test was much lower as compared to the cycle threshold value the first time round during the first wave. That means roughly and colloquially that the viral load at the time of testing was much higher. And that clearly indicates a much more transmissible variant. It also has implications for intramural spread of infection, because last time round you found that once some member of the family got infected, the intramural infection rate amongst other members of the family was almost 20% or less. But this time round, we're finding practically every member of the family getting infected. And that could be attributed to the high viral load and the greater transmissibility of this variant. The high viral load could mean that the virus within enclosed spaces can be aerosolized very easily, even by speaking. And that has great infections for preventative measures and blocking transmission.
Now, among all these numbers, the rising number of cases, you and your colleagues are also dealing with the rise of mucomycosis, otherwise known as black fungus. What's the latest that you've learnt about this particular condition?
Well, yeah, I mean, these complications are in the wake of the massive surge of infections we had, and a lot of these cases of COVID had to be treated with steroids. Mucormycosis is caused by a mold, a common fungus, and these fungal spores are commonly inhaled by all of us, but we don't get particularly afflicted by it. It's only when you have someone who is heavily immunosuppressed. In the case of treatment of COVID, because of the very high doses of steroids that are being used, that you end up getting immunocompromised patients. But I think we need to properly investigate and unravel the mysteries of where it's coming from and why it is affecting patients of COVID during their times of recovery. Is it something to do with hygiene or contamination of the medical equipment that is being used to oxygenate these patients? Because it was traced to perhaps the water used in the humidifiers that are attached to oxygen cylinders or centralized supplies of oxygen, or perhaps even in the mad scouring for oxygen that happened during the surge, a lot of industrial grade oxygen was diverted to medical use. And a lot of experts are trying to investigate this and find out if there was contamination in those sources, which is leading to this epidemic of mucormycosis. It's become a notifiable disease in India. Every case has to be informed and communicated to the Ministry of Health. And also the government is ramping up supplies of amphotericin B, the antifungal agent that is used for the treatment of mucormycosis. We are importing almost 700,000 vials of the drug on an emergency basis, because now that drug is finding itself in the black market.
Dr. Ambarish Satwik, thank you very much for joining us. It's obviously a very difficult situation there at the moment, and we appreciate your time, and stay safe.
Thank you. Thank you very much.